Thanks for having me. That sounds like it's on, yeah?
Yeah.
No, I appreciate you having me come speak. I don't know what you've heard. They had me in the other room all morning. So feel free to make this as interactive as you want. My specialty is something called autoimmune neurology. We sort of arrived at this in the neurology field. I didn't come up with it. I think perhaps the folks who trained me when I did fellowship at Mayo may have come up with it, but it's sort of meant to encompass a field, and we'll get into that a little bit. First, the bit of the housekeeping. My hobby job is doing the neurology podcast and a 5-day-a-week neurology minute for the official journal of neurologists. And this is actually, I think, really fun for me because it's a great way to, you can download those for free, by the way. They're not just for neurologists, but that's the target audience. You'll be able to tell when you listen. It's sort of a fantastic way to have dialogue among docs and challenge ourselves. You know, we can bring up sort of relevant issues from the literature, but we're also allowed to pull from anything. So that's the housekeeping bit, and that's sort of the fun hobby job. So you can tell me what you want to hear, but I just picked a few different things, and many of these you're more expert than I am about navigating care, but it's maybe a perspective from me seeing the frustrations of some of the patients that come through my clinic and some sort of advice that I've given them, whether or not they take it, I don't know. So these are some thoughts. So first we'll start with what I actually sort of set out to do in my specialty of autoimmune neurology. This encompasses immune-mediated disease affecting the nervous system, so the brain, the spinal cord. I tend to focus there, but obviously there's not a firm cutoff that the body follows, and so we go all the way out to the peripheral nerves. This often involves the eyes. And the interesting thing is, the strict definition tends to require an identified neural autoantibody, but all of us in the field recognize that the identified neural autoantibodies that we're aware of are really just the tip of the iceberg, and the rate of discovery of new neural autoantibodies tends to be on the order of about 2 to 3 per year. And not showing any signs of slowing down. That's another thing we cover on those podcasts and stuff. Sort of fire away at least a couple minutes with every new one, with the recognition that we just say to all of our colleagues, by the way, you don't need to memorize them, you just need to recognize that this exists. So this is generally what the field is. Of course, if you have an immune system so dysfunctional that it's attacking the nervous system, it's often also attacking elsewhere in the body, right? So maybe this is really where I am a closeted internist, that I really love the whole body, but I love the brain the most. I spend a lot of time talking about poop and the bowels and things like that in my neurology clinic, the skin, you name it, because the immune system also didn't read the textbook, and it doesn't tend to just go after one thing at a time. So that's what I do. As you know, if you're here, these conditions specifically live at the borderlands of medicine, and they do expose gaps in our medical knowledge. Expose gaps every 5 minutes in my clinic for me. I'm acutely aware of how little I know, and from looking at the pain in the patients and their families' faces, and sort of the desperation, and they tell me their diagnostic odyssey, and they've been here and they've tried this and that. You can appreciate. I appreciate that I may say, for example, maybe on a good day we get a nice clean diagnosis and it's like the central nervous system Sjogren's syndrome. And they go, great, well now where do I go? The rheumatologist said they don't know anything about the nervous system, and you're telling me you're not a rheumatologist, and you're gonna, that sort of thing. Those discussions happen all the time. And the other thing that I'm acutely aware of, not just from my practice, but from growing up with illness in my family, is the well-meaning people who say, oh, well, you haven't tried this, you haven't done that, you haven't done this, you should do this, I can't believe you haven't thought of that, and just the extra burden that that even puts on everything. So, strictly speaking, this is sort of what I set my clinic up to design, and it's a very well triaged clinic. I do review everything by necessity. Every referral that I see, and probably, 30% of them or less I end up being able to see them because I think they're the people I have the most promise to help, not because the other 70% aren't ill. So paraneoplastic and autoimmune neurologic diseases, the important differentiator there is the only difference between autoimmune and paraneoplastic is whether or not we find a cancer associated with it, right? So if anybody knows about these antibodies, one of the most well-known is something called an MDA receptor encephalitis. Half the time someone has an ovarian dermoid cyst or teratoma that goes with that. The other half of the time they don't, right? So that's a perfect example. For the half that have the cyst, we go, oh, it's a paraneoplastic condition. If the exact same antibody, if you don't have it, we go, oh, it's autoimmune, right? So a bit of this is semantics, and I think it's important to pay attention to our language. I also see a lot of things listed here, neurosarcoidosis. I end up sort of finding the patients in whom rheumatologic disease manifests first or most severely to bring them to a doctor in the nervous system, and then we work backwards sort of to find out, what the box is that it might fit into. As it turns out, there's conditions called hypogammaglobulinemia and a specific subcategory that has requirements within there called CVID. And this has been an area of learning for me. I work very closely with an immunologist at the University of Utah. I'm very sad he's now going to the Centers for Disease Control because they developed a center for him to lead. So he's quite good, but it's my loss. But he's sort of trying to help me through this because, as it turns out, I was accidentally finding a lot of CVID patients in the neurology clinic just by doing routine testing on spinal fluid. He called me up one day and said, what are you doing over there? And these people, it turns out, meet criteria. Anyway, all this to say that CVID is actually a dysfunctional immune system where on one hand, people get ill quite a bit and they're susceptible to infections, but it's a dysfunctional immune system, and on the other hand, it attacks when it shouldn't. So it doesn't attack when it should, and for a subset of those patients, it attacks when it should. So these are sort of the general folks that I see in my clinic because I think I can help them the most. Obviously, within there are a lot of disease mimics and increasingly a lot of genetic underpinnings to all of this stuff, right? But it becomes this sort of two-pronged thing. Some patients come to me wanting the answer, some patients come to me wanting symptomatic treatments, and the majority of patients come wanting some combination of both, all encapsulated in a tidy 60-minute visit. So this is just to sort of show you in my world, in the autoantibody world, this is already outdated. There's two more in the last 2 months that I haven't put on here since I made this slide. These are known antibodies, and this gets really confusing, right? Because there's a lot of literature out there purporting other antibodies as well, and so these are the ones that have met a certain level of rigor in terms of being reproducible, peer-reviewed literature, not sort of these journals that, pay to play. Have you guys ever heard of this? So sort of vetted by multiple laboratories, not just one person who stands to profit from a given test. And so those are the ones that are on here. And that's not to say that these other ones, everything starts in development somewhere in somebody's lab, right? But another part of what I end up doing is sort of trying to sort through things that aren't vetted, and I get it. I get why all these tests are done. I think almost everyone is well-intentioned, but I do think it's part of the job, my job, to sort of go through and say, well, here's the difference in how that was done. Part of what I did when I trained was learn how these assays are all performed in the lab, right? I was doing these assays. So I can see how not perfect any given assay is. And so a lot of times, very easy referrals I can triage straight out of my clinic are for low titer positives on some of these tests, because I know that they're meaningless, right? I've done the assay, I can see the jitter in the assay, I know how it's done. Is it a dirty radioimmunoassay, or is it a Western blot? Is it an ELISA? Gosh, they're notorious for low range as being completely insignificant. So a lot of what I do is, those are fun. I get to sort of reassure people if it was checked that that's not significant. Oh, you're on IVIG, meaningless, right? So then there's always the question of why you're on IVIG in the first place. But so some of this is simple, some of it's not. Yeah, go ahead.
So is this all blood test or is it primarily CSF?
So it's a great question. The question is this all blood tests or spinal fluid testing? And so in fact, for each of these antibodies, there's not a simple answer. So let me give you the LGI1, which is under the H there. LGI1 and Caspr2 were formerly categorized by something called voltage-gated potassium channel, which we don't use that term anymore. That's obsolete because it was a complex that was pulled down by a very dirty radioimmunoassay that captured a lot of things of that were not significant. So anyway, LGI1, for example, is much more sensitive on the serum than it is on the spinal fluid, but it presents as an autoimmune encephalitis, right? So one needs to sort of, in some sense, know what they're looking for there. Likewise, NMDA receptor encephalitis, the diagnosis can never be made unless on serum alone, right? Unless it should be in the spinal fluid. We know that the false positive rate in the serum is quite high, and it's quite low in the spinal fluid. So right, like it's different for every single antibody, and so this is sort of this is the easy stuff for me, right? I can fire this off when docs call from around the country, do this, do that, test this one on serum, this one on CSF. If you want a simple approach, everybody always wants a simple approach when I talk to rooms full of physicians. You send, if the index of suspicion is high enough, you send both spinal fluid and serum on both of these to the most comprehensive evaluation you can get, right? And even if you don't send to, I do staged approaches sometimes, right? Because the other big thing I deal with in my clinic is medical bankruptcy, right? So by the time you've gotten to my clinic, things are not in a good situation. You've been to, that many doctors. This has hugely disrupted your life or the life of someone you care for. So sometimes we will, at least in our clinic, we will draw, for example, before we would try any sort of treatment trial, I will draw, and I have my own research lab, so I can throw the serum and CSF in a freezer indefinitely, so the ability exists to test into the future, right? And some of these things fluctuate over time. So you'll see a later slide, and when I give this talk to anybody who will listen to me, save the serum, save the CSF. For the love of God, whatever you do, save the serum and save the CSF, right? Because it's different, the assays are evolving. So I told you LGI1's much better on serum. It's still not a perfect assay yet. It has a lot of problems, right? And so I'm fortunate where I'm based that I have a commercial laboratory about 100 yards from my clinic, and so I can actually call them up and say, this result doesn't make sense. I want this rerun, please. Or let's send it to this other different lab and let's compare, let's do data, things like that, because none of these are perfect. Having said that, these are a lot better than a lot of stuff you see out there because they have obtained CLIA certification, which is a very onerous process, right? It's not the end-all be-all. You can still have a bad test that gets CLIA certified, but from the time of discovery of some of these antibodies to certification and commercial availability can be anywhere from 2 to 5 to 10 years, right? And that's painful when we're looking for these antibodies, but appropriate, in order to make sure this is done correctly, because these assays are never perfect. So it's a test is a test. A test alone is not an answer. It has to fit, right? It has to fit the clinical picture. Anyway. We could get hung up on that. This is probably the most important slide. So what are the clues to an autoimmune neurological disease? So you're going to hear a lot today, right? I mean, it's, over in the other room, I think everybody sort of does 2 talks, is my sense. I'm sitting very skeptically over there. I really am, and that's my job, to be skeptical. But, one thing, we do need to obtain objective data to support theories. So if you go to a doctor and they're always certain, never wrong, we run the other way, frankly. We even say that in medicine, right? Like when we're going through training and making fun of the attendings, like, oh yeah, that's a guy that's always certain and he's never right, or always certain, never right, right? If the doctor says, this is what it is, boom, run the other way, right? Like, or if they, if I told you that all I see all day long in my clinic is X antibody, well, then clearly there's a problem here, right? Because these things should be rare. And while I may be screening, not everyone should walk away with the same diagnosis, right? And this gets terrifying when you're a patient and you're not feeling well, and you haven't gone to, umpteen years of school because you don't want to, and that's not your thing, but now all of a sudden you're trying to acquire all that knowledge on the back end to sift through this. It's maddening. So I do say you should be skeptical. I appreciate when the patients come in skeptical. I appreciate when we have discussions. And any doc you're going to participate with should. So these things are often multifocal, sometimes bizarre atypical presentations, right? Before, Joseph Delmau described NMDA receptor encephalitis, over 10 years ago now. These were patients that were in psychiatric institutes, right? And still probably are. And this was wonderful, right? This is great because we know these patients are treatable and a lot of the other ones. However, not everyone in a psychiatric institute, right? So this is where it gets muddy. if I have a family member or child who's starting to show psychosis, things like this, you can imagine I always want the history and I always want to screen for a few things, but sometimes it's not. And so we have to be careful. Doctors, by definition, want to treat, we want to fix, we want to do these things, right? And we have to be putting in constant stopgaps to check our biases, right? And I say that because I've seen both sides, right? I see people who have been through the treatment trial ringer by the time they get to me, and I go, well, we need to have a frank discussion here. Like, this stuff, what do we have to say that we should have done that to you, right? So that's kind of the approach. But this is sort of my approach when a patient walks in and sits down and tells me what's been going on. Autoimmune things can follow these bizarre courses. They can be stuttering, you can be fine for 3 months and then not fine for a month. By human nature, we all want to blame it on something that happened immediately prior. Every once in a while that works, most of the time it doesn't. So most of the time it wasn't, yes, do infections make everything worse? Absolutely. Do infections exacerbate psychiatric? Absolutely. I mean, I'm blessed not to have to deal with some of these things, but let me tell you, when I get sick, I'm a bear, right? So I decompensate. and that's sort of, you can judge for yourself if I'm neurotypical or not. So it's never so simple as we want to make it, right? So I acknowledge that any of my patients that get sick are going to do worse, but I can't say that that's the cause, and is there false causal association sometimes, right? So we have to be careful. Certainly, though, the subacute and stuttering confuses this, especially in the pediatric population, because they get sick all the time. At least adults tend to not get sick as much, so it's easier for me because I see primarily adults. My pediatric colleagues, of course, the kids are sick all the time, and so sorting that out from infection and decompensation is quite challenging. So I look for objective data to inform this, because there are so many uncertainties. I just told you there's antibodies I don't know about, but if I have objective data in a patient without an antibody that's identical to objective data in a patient with an antibody, well then maybe we're close, right? So in the spinal fluid, we do a lot of spinal taps in my line of work. These patients tend not to have the white blood cell count in the spinal fluid that's through the roof that suggests bacterial meningitis. They have the mildly abnormal one. Likewise with the protein, mildly abnormal. I never stick a needle in someone's back without obtaining a lymph clonal band profile. And I try to teach this and sort of brainwash all of the residents at our university to never stick a needle and not get a lymph clonal bands. They were always taught that you only do that for multiple sclerosis, but in fact it's an indicator of sort of non-specific antigen formation in the spinal fluid. So very useful piece of data. Sometimes in some of these well-described autoimmune encephalitis syndromes, the white count's normal, the protein's normal, everything is normal except the lymph clonal band profile. So you don't usually get the triple threat here where you get the whites up, the protein up, and the bands up. We're lucky if we get one. So that's one piece of data, one non-specific piece of data to suggest we're on the right path, right? For some of these older syndromes in older adults, when it's truly paraneoplastic, meaning related to an underlying cancer, they have, a 50-pack-year history of smoking, or malignancies running in the family. Sometimes that's a piece of data that informs the direction we take. For children and things, it's usually not that simple. Sometimes the children will have the personal or family history of autoimmunity running, your autoimmune diabetes, the type 1, lupus, vitiligo. I just threw a few things up here. Thyroid autoimmunity, please keep in mind, that's the most common type of autoimmunity internationally. So again, if someone's saying that's where everything is, no, it's a clue, it's one piece of data, right? Probably not responsible for a whole body systemic thing once under control. Thyroid autoimmunity, very common, but it's a very useful piece of data. So MRIs, you need a very good neuroradiologist or a really sort of thoughtful neurologist reviewing every MRI scan, because these can be subtle sort of abnormalities on the MRIs. PET scan we don't often get, but occasionally we can manage to get that, and that's obviously a measure of metabolic changes that might be happening in the brain. This is useful in the limbic encephalitis question, the autoimmune encephalitis question we sometimes have if we can get it. It's not critical, but again, it's a nice piece of data if the insurance company will humor us. I always tell all of our residents that if you have a new onset epilepsy in a patient who does not have a family history, who does not have a history of head trauma or meningitis as a child or a stroke, then you must always consider that there could be an immune-mediated cause to that epilepsy. These are things we weren't really traditionally taught going through our training. So these are the tools, right? Again, in summary. The neural antibody testing is cool, it's fun, it's very expensive. So it's not the end all be all, that's why I put it at the bottom of the slide, right? We do a lot of testing. You just heard the lecture before me. I work closely with Dr. Pace to do GI motility testing when patients have that complaint. I don't do it if their bowel is fine, right? So it's very targeted kind of stuff. And then it's the whole package of data. Where are the objective abnormalities, right? Where are they? We need to objectify this somehow because there's so much in life that causes fluctuations, right? Like a lot of people will get sort of diarrhea after a very stressful life situation kind of thing, right? So this all needs to be objectified and sort of pieces over time. We can't just boom, land on this or boom, land on that at one point in time. A lot of diagnoses I get off of a complete blood cell count, right? CBC or a chemistry. This is bread and butter stuff. But again, as doctors, we don't necessarily, we sort of fly through it. So that's the other thing I harp on all of our neurology residents want to order the sexy neural antibody testing and look for this antibody in the secondary. Like, let's start with the sort of a scaled approach and look at the data, right? Before we start sending off these several $1,000 panels. So these are the common misdiagnoses, at least in my sort of sample in my clinic. Sometimes it is a subtle infection. And we're coming along with this, right? Have any of you heard of next generation sequencing? Again, this is back to my always save the serum and CSF. So I have, 7 years of serum and CSF. And I have a project with somebody doing next generation sequencing on our campus now. This is an agnostic approach to looking for subtle infections, right? So I think this will help us sort out sort of some of the diagnostic anchoring that happens with people saying there's subtle this or that infection that's not commonly recognized, right? This is agnostic, so it'll either find it or it won't, and it doesn't go into the physician bias. This is a sort of cool approach. So, and again, I have serum and CSF saved from people, a couple of whom have passed away, and I'm still looking for answers for closure for the family. So the fact that I have those samples saved, right, now you can still continue to go at some of these questions. Inflammatory is a generic category, but again, like what I was talking about, sort of rheumatologic things, and you can get this from data. Again, it's sent to a good sort of certified lab. Toxic metabolic, sometimes this kind of probably could encompass true mitochondrial disease. And then I have psychiatric on here. The other, oh boy, where's it? Oh, there we go. This is important. This is where the stigma comes in, right? But something that I point out to all my patients is that if you have, let's say you have the easy stuff, the low-hanging fruit, NMDA receptor encephalitis, guess what? I'm going to give you immunotherapy and treat the psychiatric manifestations, right? Because it's, I would think, torture to just throw somebody on only steroids and IVIG while their NMDA receptors are being attacked in the brain, right? This is the receptor that ecstasy goes after. So these people are hallucinating. So if I can also get in there and chemically muck, I'm going to do it at the same time. So a lot of people that come in my clinic have already been sort of medically traumatized. And so when I even bring up this piece, I see them shutting off. I'm like, just give me a minute here, right? Like the trauma of what you've gone through, the potential that you are, almost everybody in my clinic has some sort of psychiatric manifestation, right? We draw this artificial line down the brain, neurology and psychiatry, right? It's asinine, especially when you have antibodies attacking the brain. You're going to have hallucinations, you're going to have depression, you're going to have anxiety, so one of the first hurdles I have to cover with some of the patients is, okay, we're going to look for the cause, and it may be immune, it may not, it may be something else, but by the way, shouldn't we probably treat this in the meantime so you can actually function? And this is a big, I don't know what it is, but it's a big stigma with some people, and it's often just a framing thing. They're concerned that if I call it psychiatric, I won't look for something else, right? But no, it's a component of disease that intrinsically affects the brain. You're not going to be okay, or you wouldn't be in my clinic in the first place, right? It's like not numbness and tingling that brings people to my clinic, it's inability to function, right? So this is something that we have to be careful about, and it's taking care of the whole person. So, I don't really have a timer. We can just keep talking until they get the cane out pull me over. So again, here you go. As promised, here's the slide that I give to the docs. If you are going to stick a needle in someone's back, get extra spinal fluid and save it. We generate the entire volume of our spinal fluid in whole 3 times a day. All right, so these docs are like, oh, I didn't want to take a couple extra milliliters. I'm like, they're not going to miss it, and they would much rather that than another stick of the needle in the back, right? And always get illegal clonal bands. Like I just said, it's pretty hard to have a process affecting your nervous system and not have psychiatric symptoms, right? And so on the one hand, that shouldn't distract us as physicians, right? I have patients who come in and here's the secret medical term, right? They may enhance their exam findings. Well, guess what? That doesn't mean that there aren't real ones underneath it. It's just they want to be believed, right? And so, and if you've been to multiple doctors that keep saying nothing is wrong, subconsciously, yeah, your reflexes might get more brisk or something, or strength testing, So this is where really it's, there are people that study this and are experts much more than me. But I think we need to be upfront about this. And actually as a patient or an advocate, if you're upfront with the guy and say, look, I understand that I'm coming in intense. I understand, that I seem anxious. I understand that, but this is what I've been through and I just really want an answer, right? Because, physicians all have their biases. We all do. And you walk into a room and you've got the people doing that, you're going, oh, right? So, but it's sort of a communication thing. So of course I'm anxious. You would be too, right? So doctors need to be told that is the bottom line, right? For the doctor side of things, the only way we're ever going to make headway with any of these conditions, either in the present or in the future, many of my patients say, look, I get that you might not want to, maybe it's too late for me, but let's move this forward. How can we help? Let's still try to get the answer. It has to be documentation of objective abnormalities, right? When somebody's acutely ill, absolutely, and the doctor sort of impulse, we try to symptomatically manage, but we cannot get lost in that. And again, let's say that I gave someone steroids and they got a little better. That's informative, but that's not an answer, right? And so this is sort of where the two things constantly need to be in tension, in tension with each other, right? Treating, but also trying to find out what's going on. If it's a hard to diagnose mystery patient, it's usually either infectious or immune mediated. These conditions aren't really that rare. I mean, it's my full-time job. But certainly I was taught in school that they're quite rare. There's actually been a nice paper. There's these things in medicine called the Olmsted County studies, right? That's where the Mayo Clinic is in Rochester. And it's a fairly homogeneous population that doesn't move in and out too much, right? If any of you have been to Minnesota, I don't know why they stay, but it's pretty cold there. But they tend to be homogeneous. And so they do great epidemiology studies there. There was a nice one last year where, because they also have the testing there, very good testing for some autoimmune conditions, they actually finally demonstrated that autoimmune encephalitis is at least as common as infectious encephalitis. It's sort of heresy, right? But I think the docs who treat this, both on the infectious side and the autoimmune side now, the ones that do it day in and day out will tell you that's not a surprise to them, right? It's a matter of finding the antibodies.
So this is only as far as treatment modalities. Have you ever seen CoQ10 affect autoimmune neurological disorder?
So if it's a pure autoimmune condition, it could be a helpful add-on, right, for symptom management. But if it's truly immune dysfunction, CoQ10, of the level that I see, CoQ10 would not be enough. But certainly, some of my patients take it, try it, I have no problem with it. We don't have data, but I also don't think that a trial would ever happen with, say, an agent like CoQ10 or some of these other supplements and things like that, because if we can actually demonstrate that it's immune dysfunction of the severity to get you into our clinics, that's a sort of drop in the bucket kind of thing, right? But there's also sort of to sort of follow your question, what do we do with our patients as we're trying to tweak them 2-3 years down the road? That's a great question, right? There's this maybe no one, maybe has anybody said it? I don't know. There's a tension with all of this stuff because, for example, I've diagnosed some people with there's two discussions going on at the meeting, and I hope you've picked up on this. There's this relative sense of, people say mito dysfunction, and that's a discussion. There's mitochondrial mutations that very clearly, like, you don't stand a chance out of the gate kind of thing. And that's a whole level of severity and sort of a different sphere than sort of the idea of oxidative stress and mitochondrial dysfunction, right? So there are really two very distinct sort of things there. And tweaking some of the biochemical pathways is sort of intriguing, right? In my former life, I did some of it in my PhD. I did iron and oxidative stress, and so I know this story forward and backward, and I can actually sort of tell it to suit any grant proposal purpose. But which, I mean, again, back to the bias. Realize that anybody you're talking to comes out from what they know and what they were trained at, right? I mean, I've been intrigued. I remember having attendings that took CoQ10 in training and just swore by it, and they didn't really have, per se, mitochondrial dysfunction. Some of them were trying to alter their cholesterol pathway, and these are sort of all anecdotal kind of things. We need data, right? We do need data, and that's sort of maybe where the community comes in once you get better care, right, is to advocate for that. We really do need good data.
What's your current thinking on tertiary treatments if Cytoxin and other immunosuppressants don't work?
That's a great question. I think I get to that. Sorry. Her question was what do we do when big, heavy-hitting immunosuppressants don't work for an autoimmune CNS condition? I'll sort of take it because that's the only direction I can really answer it from. So it's a great question, and it happens. We have these big immune hammers, right? When you're critically ill and you come into the hospital kind of thing, or even when you're critically ill and you, in such a fashion, you can walk into the outpatient clinic. I think I have slides on treatment in here. So I tend to take sort of it depends on the severity, how aggressively and quickly we start firing through the agents, and in what combinations. There are a lot more targeted monoclonals coming out. And this is, again, where it becomes important to have saved that serum, that CSF, and to have a rational approach to what are you trying to treat, right? You can't just say the immune system, right? We have to sort of say, does this look to be antibody-mediated? Does this look to be a dysfunctional immune system? Even if it's just immune-mediated and antibody-mediated, is it one that responds to immunotherapy? This is the other thing that people don't talk about much. Some of these conditions are not immune therapy responsive.
So
we hate to say that as doctors because it means we failed, right?
If this patient is responding to IVIG, then in that case, do you think?
So it all depends, and we should probably talk later. It depends exactly on the antibody and what the diagnosis is and the mechanism, right? It varies from central nervous system vasculitis to each antibody for encephalitis because sort of what our research lab does is we study some of these have targets on the outside of the cell. Right. Some of these have targets on the inside, right? So it depends which one, how long, what's the response, do they have underlying immune dysfunction as well, like an immunodeficiency of some sort, or there's like an entire new field now, right, with cancer treatments, all the fancy new cancer treatments you guys have read in the news, like PD-1 inhibitors, all these things, in fact, muck with the immune system and are causing classical autoimmune encephalitis, right? So we should talk, and maybe you can tell me exactly what it is, and I will give you a thought with a caveat that there is no data. There's not a single randomized treatment trial for autoimmune encephalitis yet. And so we're working very hard on this. This is being filmed, right? Recording. I'm working with a colleague in the Netherlands right now with NIH with the Neuronext sort of clinical trial program, and we're trying very hard to push one through for the obvious candidate, which is the most common NMDA. So, fingers crossed, but I'm sick and tired of not having good high quality data.
Do you see pediatric?
I do see, so I'm not a pediatric neurologist, but there are very few. There's a great shortage of pediatric neurologists with a specialty, so I will do that with a caveat of I manage them with a genuine pediatrician who sort of prescribes the medications, and that has to be a very close relationship because I'm not a pediatric neurologist. But occasionally they'll let me sneak over to the children's hospital if they have a case they think is, and I sort of just consult. to be sure, because you don't want adult docs dosing kids. We don't know how to do math and do it by weight. It's kind of how math. We used to just throw a gram in. But somebody's keeping track.
Yeah, so I'll monitor. Is that all right, Doctor?
Yeah. I mean, we can keep going, or are there more?
I think it could be better, like, just because then you don't have to repeat the question. So here,
So we're good on time.
So this question is about kids who have a range of random symptoms coming under the umbrella of autism or whatever you call it. We have tics, we have anxiety, we have movement disorders, but we've been tossed around saying you have autism. Does your clinic see those kids?
Saying you have what's the term?
Autism.
Got it, yeah.
Medically ill kids who are being tossed
You're
around.
looking for the best. Oh my gosh, what a challenge. Yeah, so we see them at the University of Utah, but it tends to be multidisciplinary, is sort of the short of it, because for me to think, right, that I can sort of have the idea. Autism is so many diagnoses, right? So many, just like PANS, it's so many, it's such a heterogeneous group, and it hasn't been studied in its necessary components. There's the autism that clearly has immune system dysfunction, so clearly, right? And then there's the autism that's almost driven by gastrointestinal stuff. And then there's, so I'm not a developmental pediatrician, but we have them, and that's who sort of I lean on. But it tends to go the other way, where they consult me and they say, I'm picking up on a signal, I've done some screening, this is, and as you know, I'm sure this is a savvy audience, some of these genetic mutations in the children who are fortunate enough to have a well-described mutation, some of them very clearly, their main effects described are on the immune system, right? It's almost like the autism piece is an afterthought, whatever that is. So it's different for every single kid.
The question is, have you ever run these panels that you're talking about on this subtype of population? Because
usually the panels have been run by the time they get to me. and a lot of the time they don't need to be if we had sort of backed up and done the initial stuff. But I'm sorry, the question again. Have these panels been run on children with autism? My general answer, I think the general answer is this is not where we should start. We shouldn't start with the neural autoantibodies because we usually have more of an answer in what we already know if we've done some of the genetic and the diagnostics to get to this autism odyssey. But if you take autism, I'm very uncomfortable with these terms, and I think I have this somewhere later. There should be efforts made to characterize it better, right? Treat the symptoms while we're trying to characterize it. And genetics are catching up. This is a fun time. Genetics are dropping in price and they're catching up. But even with the genetic mutations, the people who have the very clear genetic mutation, it comes back to symptom management, right? Because there's a gene therapy for many of these things. There is a recognition of what to monitor for, of what to focus on that sometimes is driven by a genetic diagnosis. But we still have to do the symptom management. I'm getting a little far afield from your question, but yes, sometimes there is autoimmunity with some of this. Not the bulk, but a significant percentage that certainly have been called up enough. And to also answer your question, it's never the same type of autoimmunity from one kid to the next, right? And that makes sense. Our bodies don't read the textbook. So what antigen did the person who's affected come in contact with first, and that may drive the process, right? These things are always necessarily environmental and genetic. We know this from the twin studies, right? The twins don't even act the same when they have the same mutation.
So if you know that if you tested the CSF and you know that you have autoantibodies to something, then you have a panel which you run saying that, okay, you have to test these as well, and you have targeted, say, a drug or something which works on those that can help in alleviating the symptoms.
Yeah, no, absolutely. If we get enough data, and we actually have a position paper that autoimmune neurologists internationally, I'm not on it, so I can sort of speak about it, but it's a good paper, have compiled, looking at what should be the diagnostic criteria to land at a diagnosis of autoimmune encephalitis in the absence of an antibody. And those criteria are much, much stricter than what you will find for conditions like PANS. So we are not, because we know that there are going to be 3 more antibodies next year and another 3 more antibodies next year, right? The immune system has endless targets that it can target. So we do treat, we do empiric treatment trials, is what I call them. The key is that we do them well-defined based on the data that we have with an endpoint without confounders, right? So if we're going to do a trial of IVIG, I am not at the same time going to, say that you should be also on antibiotics and we should be changing your antiepileptics and we should be changing, this is how we compensate the best we can for the lack of these large trials that we would like at the moment. It is by being objective, by defining the clear abnormalities up front, trying an intervention, one intervention at a time, ideally, unless again they're critically ill in the hospital, we might not have that luxury. But one intervention at a time with a clear endpoint, and then we repeat to see if we have made a difference in whatever the objective abnormality is that we're targeting, right? So, sometimes that's a seizure diary. Sometimes the parents will keep a seizure diary for us, right? But we also can't do it by memories, right? So it has to be the parent keeping a seizure diary. Because even from day to day, as a parent, you can't. You think maybe last week was a bad week, but how many? So sometimes it's that. Sometimes it's a GI motility, a capsule study, right? If it was highly abnormal the first time, we do this intervention, and it's better now, right? And that sort of directs. That's what we have to do. Otherwise, it's all anecdotal, N of one, placebo effect all over the place, tons of money, tons of expense, lots of heartache. We thought it worked, turns out it didn't, So that's sort of the best I think we can do in terms of being fair to you, to whether you be the patient or the advocate, sort of let's try to treat, not suffer waiting for the answers, but let's do it in sort of a rational way and not sign you up for, the drugs that I use for autoimmune encephalitis are not drugs you want to be on, right? They're not benign. You guys know this. IVIG is not benign, steroids aren't benign, rituximab is not benign, cytoxan is not benign. Now, in some circumstances, the risk decidedly outweighs the benefit. In other ones, the benefit makes the risk, people say, I don't care, whatever, because the benefit is so huge, right? So that's sort of the discussions that have to happen. The fancy institutions call this personalized medicine, right? Personalized medicine means we don't have all the answers, but we're still going to try to help, right?
But you still have more, correct?
I do, yeah.
All right, cool. So just for right now, Dr. wealth of knowledge, I just want to make sure that everyone gets all of it. So
You're rating us in, we got it. Okay.
I just want to make sure.
Just say the questions at the end.
Yeah, so just save it for the Q&A. Just let Dr. Clardy finish. That's all right.
What should we do here? How much time do we have?
10 minutes. 10 minutes, yeah. That's 30 questions.
We're going to fly through this case because it sort of demonstrates what I was telling you. You can see here I highlighted certain things. This patient didn't have a clear diagnosis but had certain signals. Normal spinal fluid except for bands. They did have an abnormal EEG, but it was sort of being called just general idiopathic epilepsy, things like that. A whole lot of negative things as well, but highlights sort of, this was at a point in time when this antibody couldn't be easily tested for, and so we had to sort of go with our gut. So I'm not going to take you through the whole thing. The point is to say we need to be thoughtful, we need to collect the data, and then we need to step back and look at the data objectively. Because, right, he was being siloed. So he was being treated by an epileptologist who was treating the seizures without finding out why he had the seizures. He was being treated by a psychiatrist. He was also a teenager. And so everybody's going, well, clearly it's not related to drugs and alcohol. So anyway, so some practical, take it or leave it. I mean, if I had $1 for every time that happens. I just saw a note where the item 1 on the plan said, optic neuritis, inflammation of the eye, lesions on the cervical and thoracic spine on MRI, and then number 2 said conversion disorder. And I was just like, what? I was speechless, and that doesn't happen very often. I was like, why do I even care about number 2? That's a diagnosis of exclusion that imply, I was angry, I was livid actually. I had the fellows with me, and I was like, who would even have the gall to write this? I don't care. There's all these objective abnormalities in it. Anyway, we had several lectures. So a lot of what I do find is my patients are doctored out. And so the luxury of my clinic is I can spend an hour for a new visit. I can spend 45 minutes for my follow-ups. And I go, well, that visit was worth more than the 15 to my primary. However, this is sort of where I say, no, there's a lot that I don't do that the primary must be there for. And my patients will also tell you I'm a nightmare to get a hold of. I mean, I feel awful about it, but it's the truth. I'm a nightmare to get a hold of. I work at 3 different hospitals. I have a research lab. I have a family on the side, right? So I feel horrible about that. I go to bed feeling guilty every night, but it is what it is. And this is where a good primary care doctor is essential, right? One, they're keeping their eye on the big game, right? For my adults, did you get your mammogram? That sure gets lost in with all this other stuff, or same for kids, like, hey, did we do, all your routine health stuff? Like, have we assessed you developmentally? Measuring heads. Like when I see kids, I don't measure their head. That's important stuff. I'm not a pediatrician though. So this is sort of my cautionary tale. Please continue to go. You can get in to see them. A lot of them are in the office more frequently and have better staff than we do in this, sort of who are trained to be on top of urgent issues all the time than a subspecialty clinic. They'll refill the meds, They will be the canary in the coal mine too, and I get emails from a primary care doc going, need to see this one, decompensating, right? And so that is a way in, right, when it's all kind of coming undone. I don't like it. My patients shouldn't have to do that, but again, it's fighting for attention. We all know this in our lives, right? So it's very important to not rely on Dr. Google. Having said this, I like Dr. Google, all right? Because the parents and the families know a hell of a lot more than a doctor's ever going to know at a visit, right? But go see them. Once you have Googled it, once you go, oh, this is not part of what you told me my diagnosis is, something's going off the rails here, go to them and ask them those questions. And the primary care, again, will either say, oh, I forgot to mention, that there is a side effect of this medicine, it causes your hands to tingle kind of thing, right? They can take care of a lot of this and do it very quickly. I do the same thing in my life. I'm a doctor. You don't treat yourself. So I question, I email them, and they write back to me, and I go, yeah, that was stupid. I should have known that, right? But this is the essential role that a primary care physician serves. So likewise, when we do have these patients on immunosuppressive medications, I lean hard. If I have someone who unfortunately needs to be on high-dose steroid for a long time, guess what? I'm going to give them diabetes. Hopefully not permanently. Sometimes it will, but at least temporarily. And their blood pressure is going to go up, and I need someone to help me manage that. Because I prescribe it in the visit, and then I say, okay, see you in 6 months, which stinks, or maybe I'll see you in 3 months with our care team, but that's not close enough. And so I will say, okay, here's your 3 months with me. In the meantime, we're gonna go me, primary care, right? So it has to be to sort of do that. Other stuff, healthcare maintenance. This is more even sometimes for adults because I treat a lot of adults. They also focus on stuff that we don't even get to in the visit sometimes, like, hey, by the way, a good diet is gonna make a huge difference here, right? And they can walk you through, this is what a Mediterranean diet can do, and let's try to do, I always say to my patients, put crap in, you're gonna get crap out, right? Like, you have to eat healthy. If you're not so entirely incapacitated that you're bedridden, let's get out and do graded exercise. Let's walk a little bit at a time. That releases endorphins, that does a ton of it. I don't have time to get to that sometimes, and so the good primary care colleagues, they will bring them in and they'll say, oh, you didn't sign this patient up for physical therapy. And I'm like, oh, right. It has to be all the pieces. So, more of that. In an ideal world, you use a single health system. This is probably one of the greatest sources of frustration to me and the patients I see. Is, I recommend an MRI, I recommend a spinal tap, this, that, other thing. And then they start calling my office in 2 weeks going, what do you think? And I'm like, well, first of all, I get those results. They're like, well, get them. And I'm like, I can't actually ask my staff to call all clinics all around the country all day long. I can't. So if you leave the system, you have to get them to me, right? Now I'm asking an ill person to get these records back to me. And oh, by the way, you know this, you call as a physician, you have maybe a higher chance of getting the records, but not 100%, let me tell you. And then you call as a patient. So, if it's at all possible, it is good to stick with a single health system. I know the challenges of doing this, believe me, and I know it's not possible sometimes. But do on the other end be patient because, if the results aren't coming to my inbox, it can be months. And my staff will call, but oftentimes my staff call 3 times. And the patients get mad at us, and I go, I feel your pain. But we sort of get hit with that a lot. So if you can keep it in a system, it's ideal. If you can't keep it in a system, I tell all my patients, you get a study done, you get an imaging study done, you don't leave without that on the disc. You do not leave. without it on the disc. Because good luck even coming back the next day and trying to get it. So you stand there and you say, I'm happy to check out as soon as I get that on a disc, right? Because, that's all, now all of a sudden, if you have to go somewhere for another opinion, they're not gonna repeat that study because you've given it to them and now they can review it, right? And you know this, doctors don't trust doctors, right? And maybe with good reason. You could probably tell me a lot of them. So, handing me an MRI report is sort of meaningless to me. In that case that I just flew by, that was interpreted as a normal MRI and it was clearly not, right? So again, data. So you're the stewards of your own data. And I recognize that I'm reaching to choir where when you're sick, it's really hard to do all this stuff. But boy, it's easy time later if you can. And if you can have the advocate, bring them, right? Bring them because they will hear so much more. 5 minutes, all right, so we won't do all these so we can talk a little bit. And then here's the other piece, right? If I manage to get this trial through at NIH, it's gonna be because there was a lot of clamoring from a lot of patients. There's these like Autoimmune Encephalitis Alliance based out of North Carolina, there's Canadian ones all over the place who have been loud and they've been vocal. At all points in an illness, nobody has the time or energy to do this, but when you do, guess what? The government, Congress, they don't listen to doctors, but they sure as heck listen to constituents who are patients. So we do go and march on the Hill and try to advocate for all the rare disease sort of stuff, but they would listen in a heartbeat to a constituent over us. And so if we want to make progress here, this is what we need to do once we get you feeling better, once we make progress. That's my kiddo from last year. She was scootering along and then all of a sudden decided I think they were doing yoga in school or something. So I feel like that's a good reminder, right? Okay, this is all the stuff, these are all the pieces. You really all need to be project managers. I mean, the best patients are engineers, right? They come in and they just amaze me. They can organize. We all need to learn to do that more. But we also need to do this, right? One day at a time. If there's anything that makes autoimmune conditions worse, it's not getting the flu so much as it is coming under emotional stress. My patients always flare under emotional stress, much more so than a cold or a UTI or infection, something like that. So this is key. So anyway, that's sort of, we can chat a little bit more, I think.
Yes.